disease?
So chronic lymphocytic leukemia is the most common leukemia in the Western countries, in Caucasian populations. And it is in many ways kind of a health problem in that it shows up more and more commonly in routine CBCs or in routine testing in asymptomatic patients. And it has a long natural history. For many patients it can mean that they for decades just only have the presence of these abnormal cells but don't really require treatment. Whereas in others it can lead to progressive leukemia, lymph node enlargement, spleen enlargement, patients become symptomatic. And so it's this dichotomy of two clinical courses that sometimes pose problems in taking care of patients. So some pretty much can only be observed, whereas others need to be observed more closely, and treatment decisions have to be discussed.
So it used to be called the good cancer, but it sounds like that it might be the good cancer for a segment of people, but for another segment it sounds like it's a much more progressive, aggressive disorder.
For that group of CLL patients who really have this progressive disease that leads to symptomatic disease, it is a very relevant health problem. It's not curable with standard chemotherapy approaches. It may be curable in a subset of patients with stem cell transplantation. It's a disease that typically, or a condition even, that leads to some additional problems, an increased incidence of additional cancers, often skin cancers, but also others. In more advanced disease, there is a susceptibility to infections, and that's actually for patients in advanced stages, that's the major cause of death, is infections. So CLL leads to some degree of immunodeficiency that can become relevant over time.
Well, it's a cancer of the B cells.
It's a cancer of B cells, and these B cells are actually still pretty normal looking, and probably what they do is really just crowd out and displace the normal immune system out of its niches, out of its locations in lymph node or bone marrow, and that over time leads to a loss of some of the normal immune function.
So what I'm hearing, that the role of the family doctor working with the hematologist would be to be on the lookout for secondary cancers, so the careful cancer screening of men and women like breast cancer, prostate cancer, are there any other skin cancer, if there's anything in particular, and also watching for infections. Any advice you would give the primary care community when working with the hematologist about what they should be looking for with their CLL patients?
I think what you said is exactly the right thing to look for. The other is to really have a low threshold to intervene, especially if more advanced patients with more advanced disease or patients who've already gone through treatment or maybe even through repeat treatments. If somebody like that calls in with a fever, it's not just a community-acquired fever. It is potentially a medical emergency, and I think these patients should be prioritized and seen rapidly, and potentially also treated somewhat more aggressively because of that.
So when we get criticized for overuse of antibiotics with the kid with a cold, in this case you're saying we should be more quick to assess them, because I understand even with a normal count, even if their white counts are normal, they're not neutropenic, they can still have an altered immune system, and what might look like a cold to someone else, for these could be a very serious infection.
Right. So what we've seen, for instance, in the last winter was a couple patients who initially started out with just a cold, maybe bronchitis, and went to see a physician and were started maybe on and even started on an antibiotic or just managed somewhat conservatively, and then within a couple days actually progressed to have severe pneumonia. One of them had a septic shock, was in the ICU. So I think maybe also just a closer observation, a closer follow-up may be advisable. That you start out simple, but if you see it doesn't, and you have to follow up, not assume that it will just go well.
Let me ask you about some of your research. Now, I know that you've done some work with a xenograph, a mouse model for CLL. Could you kind of walk us through what that is and why that might be important?
Yes, so CLL has the leukemia in the blood in most patients, and that has always given hematologists a lot of tumor material to actually work with in the lab. But what we've learned over the years is that what's in the blood is actually not driving the disease. Driving the disease is what happens in the lymph node or maybe bone marrow. But our own work has shown that the lymph node is very important in promoting proliferation.
It's classified as a lymphoma, not a leukemia.
Right. It's
confusing.
It's somewhat confusing, but the lymph node plays a very important role in activating these cells. So how do you study this? Lymph node is much harder to access than blood, and even so it can be done, it's very hard to do this, during treatment or to really model the disease in the lymph node. So how can you model this? One way of doing it is this model that we've used and are reporting on here, where we inject CLL cells into mice that are immunodeficient. So these mice don't reject the human cells. These mice have no immune system at all. So basically what we transfer establishes CLL, and also the T cells that are co-transferred establish themselves. So we get a human, to some degree, human environment in these mice. And that then gives us the ability to, do preclinical testing of new drugs, or testing a drug that's now in clinical trials, this BTK inhibitor, PCI 32765.
So let me stop there. BTK, that's?
BTK is Bruton's tyrosine kinase. It is one of the kinases that transmits the receptor, the signal from the B cell receptor into the cell.
Which stimulates the proliferation.
And survival of CLL cells.
Right. So you're blocking that pathway.
So one can block this pathway with this drug. And the question, of course, is, well, is that sufficient? Or do we need something else? How much do we really shut off? Do we shut off proliferation, or do the cells also die? And a lot of that is really hard to investigate without using a model system. And that's why we chose to use this mouse system.
Okay. One of the other classes of drugs that I know you've been particularly interested in is these immune modulating drugs, like a lenalidomide, son of thalidomide. So how does this fit into treating CLL? I know it's used in other hematological disorders. Can you give us a sense of why that would work, how that works?
Yeah, lenalidomide is a very interesting drug. Has had responses in CLL patients throughout the spectrum, from elderly patients who've never been treated to patients with multiple relapsed, difficult to treat disease. It is what we call an immune modulatory drug. I think to some degree, honestly, that means we don't quite understand how it really works. But what's clear is that it has stimulating effects on the immune system. So it does enhance the function of T cells, NK cells, and there is more and more evidence that this contributes really to the treatment effect with lenalidomide. It's also notable that if you add lenalidomide to CLL cells in culture, just in a petri dish, there is no cell death. It does not kill CLL cells by itself.
So this is where your xenograph would be helpful.
That's potentially where the xenograph could be helpful as well. Yes. Yeah. And some modeling in vitro shows that in the presence of lenalidomide, you get a better killing of CLL cells with immune therapies. So be that monoclonal antibody targeted against
So that's where I was going to go next. So help me understand what's a monoclonal antibody. And I know you've done some research with conjugated antibodies. So if you could talk about those two things, because that might be new to some primary care.
Right. So monoclonal antibodies are basically specifically targeted at one antigen. So what we use a lot in CLL or in B-cell malignancies is an antibody that specifically binds to the CD20 molecule on the cell surface of CLL cells and most lymphoma cells. What these antibodies do is they recruit immune mechanisms. One important one is the activation of complement. And complement basically punches a hole into cells. So the antibody binds and just flags this cell for attack. The other attack mechanism is cell-based. NK cells, for instance, bind to the Fc, so to the other end of the antibody, to the Fc portion, and then can directly lyse the target cells, the CLL cells. A similar effect can be brought about by T cells. And one thought is that bringing together lenalidomide and such an antibody, for instance, can enhance these immune effector mechanisms.
So we're looking here at cocktails that we've had all this conversation. We haven't mentioned much chemotherapy like alkylating agents, purine analogs, which we think of as the kind of the toxic chemotherapy. We're talking about immune modulating drugs, almost biological treatments. Is that a trend that you see happening in CLL?
Yes, I think that's a trend that's really happening also now with some of these newer drugs that are in early clinical testing, but that are not chemotherapy. They target these survival and proliferation mechanisms. So for instance, turn off B-cell receptor signaling. The chemotherapy with the combination regimen that's used now, 2 drugs, fludarabine, cyclophosphamide, plus this antibody against CD20, rituximab, is a very effective treatment regimen, and for many patients can give extended periods where the disease is in remission and there are no diseases in remission, there's no problem. It's just that the disease relapses, and some of these relapses are then very hard to treat. So the chemotherapy has its downsides. It can induce additional mutations, so some patients later have bone marrow dysplasia. It can at least transiently cause neutropenia, neutropenic fevers, worsen the immune system function. So a trend, and then quite a number of the CLL patients are really elderly. So moving away from chemotherapy is, I think, something the field would like to do.
Well, let me throw you one last kind of open question. And at this conference, is there anything that you think that's important for the primary care community that you want to share with them, or some of the new research, new data, or new directions that you think would be important for the family docs out there to understand?
I think we're a little bit in a transition right now. 2 key things are happening, and I don't think they are ripe for even hematologists at this point, and not by extension, and not for primary care. But 2 things that are happening is, one, we're starting to really define the mutation complement in the genome of tumors, including CLL, other lymphomas. So I think one thing that will happen, it will get very complex, because many of the mutations that are seen occur only in 5, maybe 10% of patients. So all this molecular testing will get much more complex. We're starting to see this wave now coming. A lot of the presentations here have this as a topic. Treatment-wise, I think what's most exciting really is what you mentioned before, is that we potentially will have the tools pretty soon to move away from traditional chemotherapy approaches. And there are a number of studies being presented, but again, these are phase 2 trials, so still relatively early clinical testing.
So kind of summarizing what we're taking away from this, what you're saying is that CLL is a heterogeneous disorder, that for some people it's a relatively non-event in their life, just an asymptomatic elevation of the white count, and for others it can be quite aggressive, that demands early and aggressive intervention, maybe as far as even a transplant. That that there's new treatment options that are out there that are getting away from chemo in certain populations, but there is quite effective chemo that is available. And for the primary care physician, he or she has to be aware of the risk of secondary infections, so I'm thinking your screening and needs to be watched, and infections can't be treated lightly. This is not an over-the-phone, you know, just take this and call me in. If you're not better in 5 days, you need to be seeing these patients and being more aggressive and following them up.
Right.
Any last thoughts? Or?
Well, I think we're talking about the patients who need treatment, and I think that's totally justified, especially in the hematology setting. But many of the patients who actually are watched for decades, potentially, some will never need treatment, for many of them there is still an anxiety about the presence of these cells, and there's the question, what can I do about it? And I think one role of primary care physicians here can really also be to provide a follow-up with a reassuring follow-up, basically, for these patients. That can be once a year, or, you know, just to help look after them and say, yes, everything's stable, there's no reason why this couldn't just stay stable for a decade. And
so
it could be
instead, it's not watch and wait, it's watch and worry. Yes.
Well, it's watch and reassure, maybe.
Right.